Hi, everybody. Welcome back to Misconceptions. I'm really honored that Julia Woodward agreed to speak with me today. I have actually met you not only multiple times, but actually had the opportunity to interview you before for Yesh Tikva. And I just love the conversations that I've had with you from before. So thank you. Thank you for saying yes.
Oh my gosh, it's such an honor to be back with you. And again, likewise, I feel the same way. It's a real pleasure to have our conversations together.
Thank you. So let's tell the audience a little bit about yourself and then we'll introduce the topic. So, Dr. Woodward, you work in New York City. Tell us a little bit about the work that you're doing.
Yeah, so I direct the psychological support program at the Duke Fertility Center, and I'm a Ph.D. clinical psychologist by training, and I've had the opportunity to be working side by side, embedded on site at the fertility center now for over 20 years. And I do
Wow.
lots of clinical work and some education and teaching as well.
You do research at all? I don't remember if you're in the research world. You are, right?
I am. Yeah, I
Yeah.
do. I have several projects afoot right now. So,
Wonderful. So we are going to take a conversation. We'll see where it goes, but we had decided on this topic of living child-free or childless. Language is based on however somebody wants to describe themselves and their experience. And I think what I want to do is like start from where you realize with your clients, with your community, professionally, where you see people beginning to make some of those decisions about stopping treatment. And I want to acknowledge also that for some people, it isn't actually about stopping treatment. It's actually about not having any more options available. So let's take from the psychological perspective of people who are in treatment, they're working things through, things are not working the way that they would like them to. What are you noticing? What have you learned?
I think the thing that really strikes me about taking care of patients across months and sometimes years of fertility care is that the emphasis in popular culture is on the success stories, right? Here's my beautiful baby from doing IVF. And that is a great joy. And it's the favorite part of my work. And that happens a lot, but it doesn't happen universally. And because of being at a tertiary care academic medical center, I sort of see the most difficult cases. And so I have a fairly decent cohort of patients who do it all. I mean, they are doing, 6 or 7 euploid embryo transfers. They are, having 4 pregnancy losses. It's like they've just been working so hard for so long and it is not working. And they sort of were like, where is my story? Everybody just sort of assumes like if you do fertility treatment, you will take home a baby. And so I'm not represented anywhere and I feel so alone.
Hmm.
I feel really betrayed by that narrative. And so it led me to want to learn a little bit more about like how common is this experience and how do we take care of people who are having that experience. Um, and so what we now know from the literature is that for every 10 patients who go through 3 IVF cycles with ICSI, 4 of those patients will not end up taking home a baby. Um,
Whoa. 4 out of 10.
4 out of 10 who do 3 IVF ICSI cycles.
Right. I want
And
to
I mean,
clarify, not everybody knows what ICSI is. So let me clarify that for people. So ICSI is when you're going to be, meaning that the embryo has been created, not just being like flooded with sperm, but actually one sperm placed inside that embryo, which ultimately gives you usually a much better outcome. So we putting everything at it, right? Am I correctly saying it?
yeah,
Like
I mean, I
really
think
everything at it.
ICSI is a way of sort of guaranteeing that your egg will fertilize or sort of forcing
Hmm.
your egg to fertilize. The idea is that it's going to increase the fertilization rate. And so I think not everybody can access 3 cycles of IVF. Let's start with that. Like IVF is often poorly covered by insurance and very expensive, and so even getting to 3 IVF cycles is a lot. Um, and the struggle is that just because you do an IVF cycle and just because you sort of do this procedure to potentially increase the opportunity for fertilization doesn't mean that you're going to get a good embryo and doesn't
Right.
mean that your embryo will implant and doesn't mean that your pregnancy that began will end in a take home baby.
Yeah.
And so I think that number really was striking to me. Um,
Sure.
And so that's, again, we're wanting to kind of have better sort of public awareness of the limits of fertility treatment. And then for those of us who are mental health providers, like to think more about like, how do we take care of patients who are having these experiences?
Yeah. Does that number reflect the same, like 65% of people who do IVF will get pregnant and have a healthy baby? Is that similar in number?
It does, it factors that in. It's that, I mean, there's also data that if you're able to do 3 transfers of a euploid embryo, you have a 95% success rate, right? So
Right.
this works really well when you have fertility treatment is highly successful when you get a euploid blastocyst. It's
And
just
so,
like the funnel of people who get to that point is actually
sure.
smaller than we realize.
And euploid means that they are chromosomally normal.
Normal.
Means that there's nothing that's presenting on slide, on deck that says this doesn't look healthy.
Yeah, it's that pre-genetic testing, the pre-implantation genetic testing that we can do of an embryo after it's been created to sort of count, does it have the right number of chromosomes or not? It's the
Yeah.
best sort of screening method that we have at this point. Although there's some controversy around its utility also. That's a different podcast.
Absolutely. So we have this group of people who, even though they've taken everything where the data says you really should have been able to, you have healthy embryos, these are two healthy, physically healthy people. We have expectation that this would work, and then it doesn't work. And
Well,
we
and
don't really
I think the
know.
key there too is that like not everybody gets to the point of having a healthy embryo. Not
Hmm.
everybody gets to the
Hmm.
point of being able to afford an IVF cycle. Even if you do an IVF cycle, doesn't mean you're going to get a healthy embryo. This is where that 4 and 10 number is coming from. It's that there's just many, many places along the way where people can experience a lack of success. And I think that is rarely acknowledged. It's not as well known sort of in the lay public. Everybody
So
thinks,
it's
oh,
really,
just do
yeah.
fertility treatment and it'll work.
What's really interesting about this conversation, which I think I has to like pause for a minute because I want to express something that kind of throws off the numbers just a little, not really throws off the numbers, but throws off the information a little bit. Many people that work within the Orthodox Jewish community are being supported financially for their processing through fertility treatment. And often, not always, but often, there really are no limits, meaning they're not saying, well, you get 3 rounds and you're done. It's usually to one live baby, and they won't pay everything. There's significant percentage that they are working to cover. There are copays. There is, donations that there sometimes even is like, we got to ask your family for help as well as us giving a percentage. But it's enough that people within the religious Jewish community, if they want to continue treatment, usually are afforded the opportunity to continue treatment, which also has its own limitations if you think about it from a psychological perspective, right? So if financially there's no real, big, like limit, and therefore I can continue to do retrieval and trying to create embryos and retrievals and trying to and maybe I get them and I transfer, they don't work. Like, then when do I stop?
How do I stop? Yeah, I've worked with patients who did not have financial barriers, were not interested in using donor eggs,
Right.
and really spent quite a period of time just doing IVF cycles and trying to create embryos, and then just getting back like all of the embryos were aneuploid. Well, let's do another one. Okay, all of the next round of embryos were aneuploid. Well, let's do another one. The cycle got canceled because you just weren't responding to the medications. Well, let's just do another one, right? And it's like the embryology is not working. Like this, no matter what we're throwing at your body, it does not always produce what we need in order to
Yeah.
create a take-home baby. And so that integrating those limits is really painful and hard,
Yeah.
especially because fertility patients are often people who can access fertility treatment tend to be people who are hardworking, goal-oriented, type A, well-educated people. And so they have learned that the way to solve a problem is to work harder. And so they're working as hard as they possibly can, and it isn't producing success.
Mm-hmm.
And so integrating that reality that hard work does not always result in achieving your goal is a really painful part of this process.
When do you like to have conversations about, how far are you willing to push this, or when is it time to stop? Right. I think in the, beginnings of therapy, often we'll say things like, how will you know you are better? Right. When is it time for us to stop therapy before we even begin therapy? Right. And most of our clients have no clue, and that's fine. But I'm wondering in this case, like, where does the conversation begin relating to stopping treatment?
Yeah.
Because I'm finding, I'll be honest with you, because I find that very often that entree into fertility care is usually like, we're going to get you pregnant by April. Like, you guys are so great, healthy, you're going to be my prime patients, and you'll be pregnant with no time. You'll have so many embryos and so many kids. Like, I really hear that consistently, with which also leads to tremendous disappointment, because, like, how did I even fail the doctor, let alone my own body is failing, right?
Absolutely. Yeah. The same group that produced this data around the prevalence of unsuccessful fertility treatment, they also found it's at the University of Cardiff in the UK, Sophia Gumero's lab. And I don't have the paper in front of me right this minute, but I'm going to pull it to the best of my ability. The idea was that patients reflected that they wished they had been given information at the beginning of care that treatment is not always successful. And the staff members, like the team members, right? That's a really uncomfortable thing to do, right? You want to go in with like all this hope and all of this promise, like, we're going to, this is going to work for you. Not only because you want to give the patient that kind of reassurance, but also because providers don't like to integrate this reality either. It's uncomfortable.
Sure.
Like, I
Right.
just want to be successful all the time.
Yeah.
Success is getting my patients pregnant, and I want to experience that. But I think what we are learning from patients who stay in treatment for a really long time without success, or ultimately choose to be child free, is that, like, hey, can you drop a breadcrumb earlier in the journey? Like, please let me know at the outset. And because it's realistic, and also they're all in their minds, they are noodling, like, will this work? They don't feel certain that it's definitely going to work for them. So we don't need to tell them it's definitely going to work for you, because we cannot know that.
Hmm.
So I think it actually deepens the trust between a provider and their patient to just say, like, we have, these are our success rates here. This is the likelihood of success for you. There are lots of IVF success calculators. We're going to do, these are all the things that we do here that are fabulous. And also, here's a realistic picture about what reproductive medicine can do and what it can't do.
Hmm.
It's not 100% success.
Who's having those conversations in your clinic? Like, are you having those conversations, or are the doctors actually? I'm not talking about like in the beginning of treatment, but I mean, when people are identifying that maybe this is not the story, the end of the story is not going to be a healthy baby. Are you having those conversations with them, or the physician?
I think it's really a combination. Our
Okay.
providers are definitely having these conversations with patients. I think that also, I get to see, I have a one-time contact with every patient who does IVF here, myself and my colleague, Dr. Schutte. So one of the two of us is having a one-time contact with everyone who's doing IVF. But there's other patients who are doing IVF, and we only are going to see a cohort of them, a subset of
Hmm.
them. So yeah, it comes up a lot in my therapy practice here at the Duke Fertility Center. But our providers are also having these conversations with patients, and I think some of it depends on, what are your financial. I think sort of the three key factors are: what are your financial resources? Like, how many cycles can you do? What is the female age? Like, what is the likelihood of success based on female age? And then the third is, what is your openness to use of donor gametes?
Right.
For some patients, that's a great pathway. And for others, they're like, that is not of interest to me.
Right. So just to clarify, donor gametes could be donor egg or donor sperm, and there's definitely conflict within the religious world as to which pathway would be permitted or not permitted, and for some there's no donor at all, and for some they would consider donor egg, and for some they would consider donor sperm. A lot less likely to get donor sperm permitted than donor egg. But honestly, one thing I think that's really important to acknowledge is it's usually being done completely on the down low. It's completely
Yeah.
being done with secrecy. Even with all our recommendations, it's still being done in tremendous privacy. And we don't have to go into why here, but to acknowledge that that's a reality. So when we come back to that conversation of like, we've kind of reached the limits, I'd like to hear a little bit about how you set the stage for that discussion.
I mean, honestly, it's often just when you've been working with somebody for months, potentially years, and they have almost ground themselves against the stone of hard work and experienced so much failure, so much loss and disappointment and grief. It's just, it's almost a relief to the
Mm,
patient to begin to think about doing something different. You know, it's like we've been working together on all of the strategies for kind of coping and holding oneself together while you're doing a really hard thing. And there gets to be a point where they just are so worn down and exhausted that the conversation about pivoting feels like a relief. It's like
mm.
they're kind of getting out of the vice. Like, I don't have to continue to do this forever.
It does feel like that. Like it feels like that when I speak with people who have been through so many cycles and so many rounds. It almost feels like I don't know how to get off the treadmill. Like I just can't figure out how to where's the button?
Yeah.
And also maybe I need somebody's permission to do it because
Yeah.
it feels so antithetical to this power passion of I want to have a child, I want to have a child. And for some, I know I can speak to the religious community, the idea of donor is not available to them or the process of donation is not available to them. And then for others, also like the idea of adoption feels also just as threatening or unavailable to them, because there's so much complexity that goes into adoption. And I think that, I want to acknowledge that like that getting off the treadmill sometimes is like they need permission to get off the treadmill. And it's not like the rabbis are going to say to them, you have to get off the treadmill. It's time. But sometimes that process is so complicated because the resulting in not having a child or a biological child is just so devastating in a world
Yeah.
where everybody has children. And I use that
Yeah.
word everybody with quotes, right? Yeah,
Yeah.
exactly.
I mean, I think really naming that grief is a critical part in helping patients to begin considering stopping treatment. It's like really we have to create a space to name that loss and honor that grief and express and process it. And then the other thing I think you said that really struck me is this idea of giving the patient permission. I think, in our world, we value determination and hard work. And so stopping treatment can be framed as quitting.
Mm,
And I really want to emphasize the ability to pivot, right? That
hmm
I do not need to sit here and beat my head against the same brick wall year after year, that I
hmm
am adaptive, I'm strategic, and I can shift. And that's being smart and wise. It's not being a quitter.
Yeah. I think it's and I think that really you pin it like you're really I think that that is something that feels so like I should just have to work harder. I think there's also I want to address as well like this feeling from a faith-based perspective of like, well, maybe the next cycle would be the miracle story. Like, how could I stop here? How do I not know? How do I know if the next round, the next treatment, the next event would be the miracle experience for me? How do you confront that?
Yeah. You can't know. We never
Mhm.
know, right? Tolerating uncertainty is one of the key skills for navigating fertility treatment. There are
Mm.
so many unknowns. Every single cycle is an unknown. Every 2 week wait is an unknown. Every fertilization is an unknown. Every pregnancy, will it end in a live birth? And will I have a baby at the end of this process? Holding uncertainty and making space for it and navigating it is so integral to the experience of coping with infertility and pregnancy loss. And so I think, that's what holds people in the process of treatment longer. Like, well, let me do it one more time because the next one might be the one. So they might need to do that a couple times
Yeah.
or more than a couple times, and then sort of appreciate like, how, where's this getting me? Where's this question taking me? Is my life moving in the direction I want it to move when I hold this as my compass, as my North Star? Or is it
So
just taking me further and further away?
So tell me how you help people identify that North Star. How do you identify if, because I think that where I get stuck with clients is that feeling of like, there are those that will say it is my entire identity is motherhood. And in a community and a culture where parenthood is so prized and so kind of normalized and so expected, and they're standing at the side looking in going, I know that's my community, I know that's my culture, I know that's my family. I'm just not in that circle and I don't belong anywhere. Like I'm literally floating on the outskirts of society. And there isn't a community of people who do not have children that are kind of gathering together and saying we're creating a community of, it just doesn't, that's not reality.
Yeah, it doesn't
um
exist. Interesting. In that faith-based community.
Yes,
Yeah.
yes, in the
Yeah.
faith-based space. And it's not like, okay, well, we found our friends and we're childless by choice or by happenstance, and therefore, we have all these social experiences and we hang out together and we go on vacation. No, none of that is happening. There is a
Hmm.
weekend, sometimes there's a weekend away, but it's going to be the same people, once a year that get away for a weekend. But it isn't something but then they disperse back into their communities, right? Like if I needed to identify the number of people in my community who are living child free, I can do it on less than one hand, right?
Hmm.
And that doesn't mean that they are not here. It just means that the disbursement of those numbers across the different communities of culture is real.
Hmm.
And so therefore it's just so isolating. So come back to that question of like, how do you help somebody identify a North Star, right? This is how I want to get somewhere that doesn't involve children.
Well, I think the beginning of that process is really almost like it's not asking them to behaviorally commit to stopping treatment. It might just be like, can we just do like a thought experiment? What could life look like if you were to pivot in this way? If you were to begin shifting away from just month after year of IVF, which hasn't taken you anywhere. So let's say that we've sort of named the grief and processed it. We've identified the isolation. It's like, okay, what will life look like if this isn't what you're doing? Despite all of your best efforts, like parenthood is just not coming and donor eggs is not an option or whatever. And so there is also some really interesting data that 9 out of 10 patients who remain childless report living a happy, satisfied life.
Mm-hmm.
And that also being a parent is not a robust predictor of life satisfaction and well-being in later life.
Mm-hmm.
And so it's like, okay, is it possible that you could create a life of meaning and connection that wasn't built on parenthood? And if you did that, what would it look like? What could it
Mm-hmm.
look like?
Mm-hmm.
How might you be invested in either something else that gives you a sense of meaning and connection? Or how might you be parenting someone who isn't your genetic offspring?
Yeah.
But it's just really beginning to like have those conversations, and they only come when people really integrate that like this isn't happening despite
Mm-hmm.
all of my best efforts. It
Mm-hmm.
creates a sense of sort of first there's a sort of like a hopelessness, but then there's kind of a curiosity because it's like this isn't happening and I don't have to stay stuck wishing for just this one outcome for the rest of my life.
What do you find people I begin to identify as you know, as a thing that will make life meaningful for them when they don't have children?
I think it really, like doing a careful exploration of the patient's values. Like, what
Mm-hmm.
is it that you are really about? Like, what do you stand for? And what gifts and strengths do you have that you really need to express? For some people, it is shifting from genetic or biological parenthood to mentoring and nurturing young people in other capacities. So sometimes it's like being really more deeply invested in their role as an aunt, or sometimes it's forming like a formal mentorship relationship, or
Mm-hmm.
like a program like Big Brother Big Sister. Like I want to I really need to be around either children or young people and pouring into them. That's really what I thought I was going to get out of parenthood that I really need to fulfill. And for other people, I've had patients who were like, I'm going to, invest more in political activism or my career or world travel, or, I'm going to take up a creative pursuit. There's a lot of different ways that my patients have sort of grappled with those questions, but it's been really inspiring to see their creativity and their passion be able to be able to play out in other domains.
And I think where that becomes so complicated for people is if the messaging from values driven, identity is family and tradition and, the generational chain and legacy, right? It falls flat for people. It just does. It falls flat. The idea of like, well, your legacy can be about mentoring other children. They're like, yeah, I'm not interested. I want to mentor my own, right? Like I have all this love to give in my life. Yes, I could do very meaningful things during the day. And at the end of the day, I come home and my home is so quiet and my
Mm-hmm.
table is so empty. And I have never had the opportunity to carry a pregnancy in my body. There's so much grief that it just feels sometimes with these alternative realities just are never going to be enough. And I do think sometimes I feel as a therapist, like almost like I know I'm supposed to encourage and support and nourish that idea. And also it still feels a little flat to me as well. Right? It
Interesting.
still feels like I'm almost like trying to promote an idea that I understand. I don't know that I believe in it 100% because I
Interesting.
understand the reality of that their thought process is not distorted. They're just the idea of that life in our religious world so deeply centers around family that the absence of family really is a catastrophic feeling. And moving from that catastrophe into what now is really as hard as they feel that it is.
Yeah, I think that is so real. And I would never minimize the agony of this
Mm,
experience. I
yeah,
would never sort of say to a patient, like, oh, yeah, this will be easy and you're just going to make this shift. It's just sort of like, what's the alternative?
that's the thought that it comes up. Right,
Right? It's
right,
like, okay, I'm
right.
with you, like legacy and genetics and, the family chain. Yes. So keep going. But after some period of time, when that just never, ever, ever works, what it's sort of like, then should they just stop living? It's like there's got to be like another way forward. And so all
Yeah,
kinds of things would come into my brain. Like again, it would the very first step has to be honoring that this is not what they thought their life was going to look like.
exactly.
It's not what their culture and community told them their life should look like.
Right.
And they may have to like radically grieve. They will have to radically grieve that they're
Mhm.
having to shift gears. And also that shifting gears is a choice they can make so that
Mhm.
hopelessness is not the only other option.
Mhm.
I mean, the things, if a patient then was like, okay, this is devastating and I have grieved, I think or I am grieving. This is not a one time, this is going to go on for the
Sure.
rest of your life. Right. This
Correct.
is for the rest of your life. You're going to be like, oh, that's not really what I wanted. It's not what I dreamt of. But it doesn't mean that my life can't have purpose and joy and connection while I'm holding that grief. Like this is
Yes.
with each
Yes.
hand we're going to do. And
Yes.
so it may be, I mean, some of that is like, that data that by the time a child is 18, we've spent 80% of the time we're ever going to spend with them. And so parenthood is a chapter, even if you get to have it.
Mhm.
Um, More and more people today are experiencing infertility. More and more young people are choosing not to have families at all. And so this idea that there's only one way of living, there's only one pathway, it's just falling by the wayside. Like other
Mhm.
stories exist.
Right.
It may be that if you are in a community and the only way to be in that community is to have a child, then you may need to develop an additional set of communities that
Mhm.
that
Mhm.
original community is your foundation. It is potentially your faith. It's your family. It's really important to you, but it can't, if it's no longer reflecting all of your life experience, who else is out there that you could be spending time with that can meet some of the rest of what you are.
Right.
And
Versus
so I
what you're
think it's like
missing.
that radical flexibility.
And I think what you're saying is like it's not only about what you're missing. It can't, your identity cannot only be about what you do not have. Your identity has to develop into who am I, even though I don't have children, or who am I
Yeah.
independent of not having children. And that is a really big stretch, I think, for people in the religious world where so much of identity is wrapped up. And to be very clear to anybody who's listening, I want to be clear that you are not excluded from the community if you do not have children. It's just a feeling of absence, right? So for in a family centric environment and tradition, not having that is a very complex space to be. And to be honest, if we're honest about our religious tradition and religious faith, there have been many people in our history, right? Our forefathers and foremothers all struggled with infertility. This is a narrative that goes back into that stands the test of time.
Mm-hmm.
And yet, this is a deeply, family centric experience. So just be clear that they're not excluded. What I wanted to hear from you is, though, a little bit more about what do you feel or believe the consequences are for somebody who just continues to plow ahead, treatment after treatment after treatment, and is unwilling or unable emotionally to confront the getting off the treadmill. What are the consequences?
I mean, what I see is that patients just become profoundly depressed.
Hmm.
They're so hopeless. And the other thing is that every cycle, it's just so punishing. It's
Mm.
every single step in the process becomes just more and more punishing. They don't have much hope and they feel like they're kind of going through the motions. And even some of the even some of the initial anxiety that is so common among fertility patients starts to be ground away. They're not even anxious anymore. They're just like they dread it and they don't think it's going to work and they just feel hopeless.
Mm.
And so that is a place I always say, pain is such a powerful motivator for change. And only when it becomes kind of this miserable are patients in a position to be able to say, like, I don't want to do this forever.
Hmm.
I get to choose something else because this isn't working and
Yeah.
I'm miserable.
Yeah. Do you follow your patients after they've done, I mean, what kind of opportunity do you have to like follow them upon discharge where they're like, I think we're done? What kind of what's your follow-up looking
Absolutely.
like?
Yeah, I do. I have the great pleasure. I kind of keep them, really. I kind of get to stay, work with patients across time and sometimes across years. And I think that's why I feel so comforted by the resilience that I see patients exhibiting. I mean, it is an incredibly painful process to let go of the dream of genetic parenthood or
Hmm.
biological parenthood. And time continues to march forward. And so
Yeah.
patients do build other lives that are really beautiful and inspiring. And sometimes that means they did donor conception, sometimes they did adoption, and sometimes they choose child-free living. I've had patients who've moved into all of those pathways
Hmm.
and really built a beautiful life. They continue to have moments where they're grieving that the
Yeah.
original story never came true, but they're not just, stuck forever with unsuccessful treatment cycles.
It's really it's an interesting thing to hear, and I wonder about like, for those of you who are listening that are therapists, like about supporting somebody in that transition from the trying and continuing to trying into that transition of we are going to stop and actually choosing to live without children at this time, not via adoption, not via donor, like that the only option for us right now is living without children. And I'm wondering again, from a therapist perspective, what do you want us to know? What do you want us to be thinking about?
Well, I think it's so important to appreciate the the culture and the community that we're in, right? We do live in a very pronatal society, even outside of sort of a religious faith
Yes.
community. And so kind of developing a language, like how am I going to communicate my story to other people in a way that feels authentic and succinct? Because you're going to go to a gathering and someone's going to say, oh, do you have kids? And you need to have like a ready answer for that. Um, and I think having a practice for like processing the grief as it kind of comes in waves over time, it'll change and evolve. And then, really being deeply engaged and invested in something else
Mhm.
that matches your talents and your curiosity and your values. Um, it's a really critical part of the process.
Talk to me a bit about relationships. Like, what do you notice goes on in these marriages? I want to specifically focus on heterosexual relationships. What are some of the relationship challenges or benefits as you see people progress through the space?
Yeah, well, that's such a great question. Getting in alignment with your partner around this choice is a really critical therapeutic task, right? If one person is like, I'm done with all these cycles, like I don't want to do this anymore, and the other person's like, no, no, we don't have a baby yet, like we need to keep going, right? That could create a lot of friction and tension. And so, sort of working to harmonize patients with where they are in this process is really critical. But again, coming out of this lab that's done a lot of looking at what are the outcomes for people who are child free, long term, 9 out of 10 couples report continuing to have a connected and happy relationship in marriage. So it isn't like a predictor of relationship decline or divorce to remain child free.
Was there a differential between men and women in terms of their life satisfaction, in terms of their being able to I think there's a difference between their grief, but I'm wondering what you experience. Is there a difference in the grief experience, of the stopping experience, of the I don't want to do this anymore experience?
Yeah, I don't think I've seen empirical data on that,
Hmm.
but anecdotally, certainly clinically, I have. Um,
Yeah.
and I would say, yeah, there is much more of a gendered expectation for parenthood for women. And so the process of shifting to being child free is often a little bit of a harder road for the female patient, or at least she's expressing it more clearly than the male patient. Um, yeah, I do think there are, but I think that pain of not having the experience of being a genetic father, is we do know that men hold the value of becoming a parent equally to how women hold the value of becoming a parent. It's not that women want to be moms more than men want to be dads. And so I would imagine that the pain of not achieving genetic parenthood is similar across the sexes, although the expression of it is probably different.
Interesting. And the stopping, do you find one more quick to be willing to stop trying further?
I would say that I see a lot of husbands who are ready to stop because they're watching their wife go through treatment
Yeah.
cycles, and
Yeah.
it's just agony to see her suffering so profoundly. And so they're like, I don't want to do this anymore. This is terrible to watch you suffer like this.
Yeah.
And sometimes it's that hearing that from the husband is what helps the wife to begin to consider shifting gears.
Hmm.
And again, I think it's so helpful in the early stages of this process. Is not, we're not asking, no one's committing to anything, no one's going to stop doing anything, but we're just going to start imagining a different path,
Hmm.
and that can be a helpful first step for people.
I think it's important for us to at least, bring up the conversation about people who there really are almost no options for treatment. So I'm specifically speaking about men with azoospermia who really have no sperm or such poor quality sperm that the option of pregnancy isn't really there. And
Mm-hmm.
so, I have worked with many couples, unfortunately, over the years where this happens. I want to put out a PSA, which I like to do every once in a while, public service announcement that we have a cluster of people that maybe were exposed to mumps in childhood. Um, Again, underdocumented, but definitely curious about this cluster in New York City of people who are sterile. And it's a real question, and they were unvaccinated. And so I just want to be really clear, if you are hesitating on the measles, mumps, and rubella vaccine, this would be something, if like, I think there should be a PSA that says, like, do you want to be a grandmother? Give your child the MMR, right? Because there is a risk of sterility for people who have or were exposed to the illness of mumps. So I'm gonna put that out there.
A
But
great
I
data
have
point.
Right. I think that, but I want to bring up this point of there is this group of people who don't even get to do treatment, right? They don't get pregnant. They don't get pregnant. They go for testing. They usually, in my community, often are just testing the woman at first. They're going to go a couple rounds of Clomid. Nothing's working. And then they test the sperm and they realize there's nothing there. Like it's really, really nothing there. They might go through trying to do some modification of lifestyle. Maybe they're going to do something called a microtesting procedure to see if there's anything in the sperm tissue, in the testicular tissue. And the results are zero, right? Or if the results were one or two that were unsuccessful to create an embryo. I think we want to address where it's not about there is, stopping treatment as much as there is no treatment. There
There's
is
no
nothing
on-ramp.
more. Yeah, yeah,
Yeah, that's
yeah,
not even an option.
yeah. Talk to me a little bit about what you understand from the profile of of these individuals who will not be able to become parents, and they find that out pretty quickly in the regular way of becoming a parent.
Yeah, I think the thing that's interesting to me is how frequently, in this sort of scenario that you're describing, how frequently it is that the male patient with severe male factor infertility, he doesn't have anybody no one in his family has this problem. And it makes sense. Like if it ran in the family, like, probably would have been in people's awareness before this. So it is
Sure.
like this kind of de novo or maybe environmental cause. And so it's, really just like being hit with a 2x4. It's just incredible shock to integrate that something that was just an assumption. I just
Mhm.
assumed I would be able to be a father genetically. I assumed I'd be able to pursue fertility treatment if we were having trouble at home, and all of a sudden the rug's been pulled out from under my feet, and it really
Mhm.
is shocking and devastating for patients to have to integrate that, and often it's equally shocking and devastating for the female partner, for the wife, who was like, whoa, like I really wanted to have a baby with you.
Mhm.
And sometimes the wife is really able to express her grief, with greater emotion, and the husband is maybe being a little bit more stoic.
Mhm.
But yeah, it's a really difficult experience for patients to go through.
And I've seen also where the wife is going to be a little bit protective of not making him feel bad, right? He's going to be protective of her when it's a female issue. She's going to be protective of him when it's a male issue, but also recognizing that there is something in the middle between them, right? There is something here where it's a little bit easier when there's unknown. We don't know why these IVF cycles have not been working. But when there's a known factor, there is a really complex piece that's now like smack in the middle of the relationship. And that if childless or child-free living is the outcome, then there's always this kind of magical thinking around, my body worked. Like my body probably could have had a baby, but because I married this person with this issue, I can't have that.
Yeah.
Um,
I mean,
and it's
I even hear
devastating.
that come up in couples where they're like, you should divorce me and marry someone who is
Oh,
fertile.
for sure. Yeah.
And often the partner who hears that is horrified. They're like, "No, I love you. Like,
Right.
I
Right.
don't want to be a parent with some other random person. I want to live with you,
Right.
and be your partner throughout the rest of these decades. And if we need to figure out how to, integrate an identity as a child-free couple, then we're going to do that."
Yeah. And I think they're not as eloquent as you just said it. I think it's something that takes process and time and like, development of that conversation with time. But I think the feeling is there. I
Yeah.
will say that I have worked with very young couples who find this out very early in the relationship and actually do question whether they should stay. They're
Yeah.
like, I'm 20, 21 years old. I have 20 more years of fertility ahead of me. Like, am I really locking into this reality?
Yeah.
And when there is no option of donor, then I really know that there's very little science right now available to change that is not that, and therefore it's not changing so quickly,
Yeah.
right?
Yeah, and
Um,
with what you've described around the sort of cultural, community, religious constraints of like, I will be on the sidelines potentially in my community forever now.
correct,
I can
correct.
appreciate how that might change the calculus.
Exactly. And what's also fascinating is if there was a conversation about infertility, it's almost always it's assumed that it's a female issue. It's always assumed it's female. And for all those that are listening, it's at least 50-50, right?
Mhm.
We're really understanding it as 50-50. And I think that that's tough for us to kind of wrap. I think that really complicates cultural component of it, of the assumption is it's female driven, and when it's male driven, it's usually never talked about at all.
Oh,
Like you said,
that's
I've never
interesting.
met anybody else who had this. Yeah, because they're not talking about it,
Yeah.
right?
Well, also too, it would be like they wouldn't have had, if your uncle had it, I mean, if your dad had it, you wouldn't be here. If your uncle had
Oh,
it, you wouldn't have cousins, right? It would be like it shows up in the sort of evolution of the family if it's a
right.
genetic cause.
Which I'm curious to hear from you, a little bit off the topic, but like, what kind of genetic causes do we have for male factor infertility? Like, what would the diagnosis be typically?
Well, I mean, some of the diagnoses I see are things like Klinefelter syndrome.
As
Um,
and those that has a genetic component to, meaning a
mhm.
familial component to it, that if
Yeah,
one
you
person
probably
has it,
have hit
somebody
the
else would
edge
have
of
it.
my like
Okay.
expertise here on
Yeah.
like being able to give you
Yeah.
like the most common genetic causes of male factor infertility. I don't know if I'm going to be able to pass that multiple choice
Right.
test.
Yeah, I guess I more understood it as like these, and I could be completely wrong, and it's something that I need to look into more about, like Klinefelter's. I didn't understand it as having a familial component to it. And genetic, yes, where there's other disorders of development that have infertility as a genetic component to it. I wasn't aware of ones that were familial, meaning that if your
How are you
uncle or cousin,
distinguishing between? I mean, families
meaning
share
that other
genetics, and so if they
people that
pass through the family, they pass through the genetics.
right, meaning that I have an uncle who never had children, and I have that, or I had a brother who doesn't have children. That means that there's something in the genetic line that is presenting within the family. I didn't think Klinefelter's was one of those. I thought that was more of a disorder of development, like something happened in utero that your embryo created a Klinefelter presentation.
There is
You're
a
saying otherwise?
yeah, there's a genetic like it's like 46. I can't do it right now, but yeah, there's like a
Okay.
genetic, like Klinefelter's is something you can identify in a genetic test.
Hmm.
And so, yeah. But I
Okay.
think again, I think like in this context, like what I would say is most common is not that there is a genetic underlying disorder for the male factor
Right.
infertility. It's sort of a de
Like
novo presentation.
like we
And
just don't know
so,
why.
yeah,
Yeah.
yeah, I'm the
Also,
only
also
guy in the family who is
right.
experiencing this.
Right, right. Yeah, there's so much here. I mean, sometimes we hear things like, for example, just to give clarification, like somebody who has like, um, um, oh my goodness, factor X, like a factor. Oh my gosh, blanking on the word. Like where there's a genetic family disorder that one of the byproducts of that is like a low ovarian production, like poor ovarian reserve,
Mm-hmm.
and so or premature ovarian failure. So that means that anybody who has a presentation of that diagnosis, Fragile X, not Factor X. Sorry, I'm
There we
glad I
go.
remembered
Yep.
in my brain. Fragile X syndrome. So you might be okay, but if you're a carrier of it, you can have premature ovarian failure. So
Mm-hmm.
anybody in your family that is a carrier or has Fragile X would have a similar thing. That's what I'm differentiating as what's familial versus
Mm.
a genetic issue. So it doesn't matter for the conversation, but we'll have to tease that out with a geneticist and figure that one out
Yes,
together.
that'll be your
But
next one. Your next
exactly,
podcast. We have
exactly.
a genetic counselor in here to help
Exactly.
school all of us.
We can pretend we're doctors and lawyers and India, we do everything, but
Yeah.
didn't work.
We're adjacent.
Exactly. We just watch and admire.
Yeah. Well, we
Tell
have to have
me,
enough of a grounding in these topics that we can
yes,
not
yes,
be asking our patients to spend a therapy hour explaining to us what they're going through.
exactly.
But then our expertise really needs to be in, how are we supporting patients with evidence-based strategies for coping with these experiences?
Exactly. Talk to me a little bit about maybe some of the myths or misconceptions as we close out this morning, like a little bit of so a few one or two misconceptions that people have about living child free.
Well, I guess I would say like what first came to mind was, the misconception that IVF is always successful.
Hmm.
And then the other misconception that having kids is necessary for having a rich and meaningful life,
Yeah.
or the misconception that our marriage can't survive if we don't have a kid.
Yeah.
And the
Yeah.
data really doesn't support any of those things.
Absolutely. And I don't think that the culture does either, right?
Yeah.
Meaning like I think if I look at it from a cultural perspective, there has to be room in our communities for people who do not have children. And especially, the idea of having no children by choice is a very foreign concept within the religious world, almost like zero. But I would say to you, having no children, not by choice, is a reality. And I think we as a community really need to stretch a bit to think about what does this child-free living mean for these individuals, and what does it mean for them to be included? And what does it mean to really create an inclusive environment for people who don't have the things that maybe most people have, and supporting them living this meaningful and productive life and being a valued and treasured member of our communities. So something to think
Yeah,
about.
I love
Thank
that.
you so much. This was a great conversation. Thank you.
Oh, I thoroughly enjoyed it.